interest of time, I guess we'll get started as a few people get settled in. Welcome to Pediatric Grand Rounds. I'm Dr. Gayatri Shankar in General Pediatrics here at ETSU. Just to remind everyone, if you haven't already done so, please call the number on the screen. It's also in the back, in the corner, 423-200-3259, and your event ID is 345011. Also, to please remember and complete your evaluations at the end of the session because this is required for CME. It is my pleasure to welcome Dr. Alan Musil to our Pediatric Grand Rounds. Dr. Musil is one of our own. I didn't realize this till I looked at his CV. He actually did his med school here at Quillen, prior to which he did his undergraduate at Vanderbilt as well as a stint at Dallas Theological Seminary. He's, I think, one of the few people that I know who is triple boarded and is triple boarded in Gen Peds, in child and adolescent psychiatry and adult psychiatry, and has been practicing child, adolescent, and adult psychiatry for over 20 years now. So he brings a wealth of expertise and experience. Apart from his psychiatric experience, has also worked as an ER physician and pediatrician, has been the medical director, both inpatient and outpatient, for child psychiatry services. Currently, he is the medical director and child psychiatrist for Frontier Health, and also has an appointment here with ETSU as an assistant clinical professor, as well as with LMU, teaching pediatrics and psychiatry. He's also on our Tennessee Board of Medical Examiners. Again, an interesting fact that I did not know till I looked at his CV. Is definitely an expert in ADHD, mood disorders, autistic disorders, and I think brings great expertise to us for his presentation today on anxious kids.
And an all-around nice guy. I need to switch the slide set over, so bear with me. While I'm doing this, try. Okay. And I'm going to stand out here up front. Hopefully you can hear me. If it gets too loud there, somebody will be in charge of the door. I want to make sure I know, if you're a pediatric resident, just raise your hand so I'll kind of know who my audience is. Okay, all right, that's great. Okay. My goal is to make this very practical. What I'm really telling you is this won't be very academic, and it seems like I'm really loud. Am I?
No.
Okay. All right. If you have questions or comments, if you throw food, I will answer. So please, I think we're small enough to where we can probably interrupt and ask some questions. Let's just go straight ahead. Okay, these are the objectives. The first three are not all that important. The fourth one is the most important, and one of the things I really want you to take away with this. I want you to be able to identify classes of anxiety drugs, just not serotonin drugs, so underline that. Number two is, I want you to understand why you might want to medicate. We don't medicate all anxiety disorders, so I want you to have some ability to kind of differentiate the two. Number three is know some basic side effects of serotonin drugs. And the fourth is complicated. So I'm going to read it to you. List 2 things that a primary care provider can do when interacting with school systems. So I want you to come up with some ideas of what you could do when you're interacting with where the kid goes to school if they have an anxiety disorder, particularly if they're not attending school because of that anxiety disorder. There's lots of reasons kids don't attend school, from thug to parent to all kinds of stuff. I'm talking anxiety here. Okay? All right, disclosure. Oh, true, false. My goal is not necessarily for you to get the right answer to this as much as a comfort level with this question. Okay? And sure, I do want you to get the right answer, but 45 minutes from now, I would like for you to feel very comfortable as you look into this and had to deal with this if this were your own patient. So I'm going to read this to you as well. You're treating a 10-year-old child, I don't care if it's a guy or a girl, refuses to attend school because they're very, very anxious. In fact, it's so severe that truancy charges have been filed. Okay? And that happens a lot. I see 4 or 5 of these a week. A month. And they're at risk of removal from parents. So if you get truancy charges, you first go before the judge, and then you get on probation, and you scare the parents, you scare the kid, you force treatment, you build up treatment with the bully thug of the courts. And if that doesn't go well, then you're at risk of removal. You're put into a group home, basically taken away from your parents, where you basically go to school where you live. Okay? So the question is, starting medication is appropriate in this case, true or false? Whether you know the answer right now or not, that's not my real goal. My real goal is for you to feel comfortable with this case. I am a speaker for Novartis, and I will not be discussing that drug. It's a schizophrenia drug. Okay, if there's an outline to this, and there isn't much one, this would be it, definitions. The main reason I left this slide in here is to let you know that the handout that you have of my slides includes 15 to 20 slides that I will not be sharing with you. And those are definition slides. So, I'm not going to discuss the DSM-4 or 5 criteria for separation anxiety disorder, for GAD, generalized anxiety disorder. That's left to you. I'm going to try and make this more practical than that. So I'm going to lump basically all anxiety disorders together. But one slide will list them off for you here in a few minutes. Okay, I'm going to spend way too much time on approach because to me that's the most important thing. Okay, treatment is the easiest part of it. Okay, a couple of definitions. I think everybody in here is familiar with anxiety because we all have anxiety. Okay? Some anxiety is wonderful. Some anxiety is terrible. All right? Hopefully I had enough anxiety before doing this presentation to what? Prepare. Develop some slides that I hope you find interesting. All right? Enough anxiety to what? Put on some clothes today. Enough social anxiety to dress appropriately. All right, what else? Hopefully I have enough social anxiety to be on time, pick my nose. Right? There needs to be a middle ground of anxiety that's important. However, I could have been so anxious that I was even thinking about this, maybe not prepare the slides, maybe steal them off the internet, blah, 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 blah. Okay? So we're going to try and take a whack at that. All right, there is an enormous difference between fear. Ta-da! There's an enormous difference between fear and anxiety. And I have all kinds of slides and all that about differentiating the two, but we don't have the time to go there. So I thought I would give you a Rorschach test. You ready? On the next slide is going to be a picture. And within seconds, I would like you to blurt out either the word fear or the word anxiety. And I think with this picture, you'll understand the difference. So everybody ready? Okay, blurt it out. Fear. Does anybody consider that anxiety? I don't. Maybe thinking about it might make you anxious. To me, that's fear. We'll do a few more as we go. Okay, so now we're going to work towards an anxiety disorder definition. This is not the definition, but we're going to work towards that because I want you to think, well, if some anxiety is wonderful and some anxiety is terrible, how do you come up with a definition of a disorder? Okay, so you're going to have to take these things into account. First of all, a lot of anxiety is wonderful. I've already kind of said that. If I go up on a high building, if I go up here and I walk up to the edge, how will I feel? Nervous, scared, right? Maybe fearful. What does it make me do? Yeah, I have some anxiety over paying my house payment. What does it make me do? Makes my butt get in the shower and come to work. Okay? All right. However, ongoing excessive worry that interferes with everything, well, it might make me never buy a home. Right? Who wants to ever have a house payment? It's too nervous, too scary. I think I'll just rent for the rest of my life. Okay? Then we bring up this last issue of developmental. Right? We're all pediatricians in the room. And so there are some things growing up that are completely normal to be anxious about. So how do you incorporate normal developmental steps in the definition of a disorder for anxiety? And I hope to give you a good answer to that. Okay, so if you look at all of the DSM-4 and all of the DSM-5, and hopefully you know what that is, they all incorporate these criteria. So I've lumped them all together, so I'm going to work my way through this. So if you go to obsessive-compulsive disorder, it's going to incorporate this into it. PTSD incorporates these definitions into it. Okay? So here goes. Has to be persistent worry or fear. By the way, the DSM doesn't differentiate between anxiety and fear. They use them interchangeable, but they are very different. Got to have a certain amount of distress. And the big time word here is dysfunction. You're going to see that word way too much. So I would like you to think, what does a functional 3-year-old look like? What does a functional 7-year-old look like? What does a functional 12-year-old look like? And then we're going to compare that to the word anxiety disorder. I'll give you some examples. It must be time-consuming. So if you have terrible obsessiveness for 30 seconds every morning to put baby powder in your shoes, incredibly obsessive, does it matter? Who cares if you spend 30 seconds a day doing baby powder in your shoes? It might meet the full criteria for OCD, but it's not time-consuming. Does that make sense? Okay. And then exclusion criteria. Every one of them have exclusion criteria. All right? And so you've got to be able to rule out, like, drugs, right? Methamphetamine, does that make you anxious? You think of drugs that you prescribe and I prescribe that's not a standard drug that would do that? Steroids? Anybody prescribe albuterol? Okay, so there's lots of things that could make somebody look anxious that you might be causing. We'll do a different. Okay, I'm going to do another one of those Rorschach tests. I'd like you to blurt out the word normal or abnormal on this next slide. You ready? And you have to do it within seconds. Normal or abnormal? Why is it normal? Say it again? Yeah, Santa does look like a freak, doesn't he? Or he's been drinking, one or the other. Or one of the kids just wet on him. Okay, so object permanence, separation anxiety disorder. When you're born, when you can't see stuff, it doesn't exist. At some point, when you can't see stuff, you still know it's behind the door. It's away from you. It still exists. And that's when separation anxiety kicks in. That's when you know you're not with your mommy, you're not with your daddy, you're not with your caregiver. Okay? Completely 100% normal. Should start around 6 to 7 months. Max is usually 12 months to 18 months. By 2, it should be significantly better. By kindergarten, it should almost be gone. Okay. All right, this is what I was taught in my residency. It's not completely correct, but I think it's the best thing to remember. That is, all infants and toddlers have anxiety problems. You need to view that as normal. Really important concept. Okay? So the parents should come in, particularly first-time moms, right? We pick on them. And they should say, my kid just too anxious and nervous when I walk out of the room. Okay? And that would be, oh, I understand. You would give some comfort. You would tell them how normalized. You would reframe that if we're going to give it a psychiatric slur. Okay, but by kindergarten, about 10% will meet a criteria for that DSM disorder, anxiety disorder. Teenagers, 15%. Adults, 20%. I'm going to throw a couple of other studies at you that's a little bit of variation. I was taught 2 to 1. The answer is actually 3 to 2. So we kind of picked on the females there. Huge genetic component. The more research we do on anxiety disorders, the more we know that genetics has a lot to do with this. Actually, I thought I hid this slide, but I guess I didn't. It's in your packet, but here's the 3 to 2, the female to ratio. In this one, and this is a 24,000 study of teenagers, almost 25% met criteria. Now, they had a pretty wide definition of an anxiety disorder. If you use a really severe disorder, it was only 5%. So it kind of gives you the range here. Okay, this is an interesting study because, first of all, it was published January 2014, and it's, I've forgotten how many counties. 11 counties in southwest Virginia, basically the Appalachian Mountains. And it did include some Native Americans. Okay? And it was a 13-year study involving ages from 9 to 26, so they followed them for how many years? 13 years. And they wanted to see how many developed an anxiety disorder according to the DSM-4 criteria. What's the answer? About 20%. Okay? All right. What causes anxiety disorders? This one says what? Into the house, children, there's a gentle breeze blowing. Maybe that's a cause of an anxiety disorder. This is probably the article, it's a review article that I see most often quoted as far as causes. But certainly there is a temperament. Everybody hopefully knows about temperament. About 65% of all children can fit into a easy, difficult, and slow to warm up. 35% won't fit well into any of those. Okay? However, if you're slow to warm up, you're at much greater risk of developing an anxiety disorder. Okay? All right. If you have a significant medical disorder when you're very young, that increases your chance of having an anxiety disorder later in life. The problem with that comment is we don't know if it's because of the kid and their medical disorder or procedures, or is it the way it impacts the parents. because both could. Okay? An endeared child, hopefully everybody's familiar with that term. Chaos, which is mostly what I treat at Frontier. Kids that live in chaotic homes where mom or dad's busy trying to get the next drug, the next sex, the next get the lights on, the next lover in their room. They're going to move from house to house to house and expect the kids to handle it as well as they do. Okay? And then overprotection. And there is proof that overprotection does lead to anxiety disorders. Okay, next couple slides are what will show up in your office. What is this supposed to represent? Somatic symptoms. Okay, and they're real. Let's give a real example. I'm sorry, I'm kind of ignoring this side over here. About 3 months ago, I had to get up in front of 500 doctors and give an hour presentation on something I didn't know all that much about. Okay? What were my hands doing before I got up on the stage? Yeah, they were sweating and probably a little bit of a tremor. Okay, what was my heart doing? Under 100 or over 100? Yeah, now my heart rate's usually around 60. But before that talk, it was over 100. What was I doing as far as my breathing? A little fast, probably a little shallow. Was I sick? Did I have pneumonia? Contagious? No. How about exercising? Was I running a marathon? Because all those things could happen when you're running, right? Exercising. What was I? Scared to death, fearful of 500 doctors? Looking like a fool, looking like an idiot, like I don't know what I'm talking about. Okay, now after up on stage for a couple minutes, those things went away. Okay, completely normal. Now, let's figure out if I was faking. Was I faking it? Really important question. Come on, guys, make some decisions here. Was I faking it? No. Were my hands really wet? Yes. Yeah, but I wasn't faking it. So what was causing it? My emotions are connected to my body. Okay? I've seen people paralyzed from the neck down from feelings. I've seen complete stocking glove paralysis from talking to grandmother and cussing her out and your arm going numb. You'd be amazed at the kind of things I see related to that. Okay, so this could present. Now, what is this one supposed to represent? Come on, think with me. What's it supposed to represent? In my mind, it represents poor concentration. You could say this person has ADHD. Or they could have fear of heights. What if you had a terrible fear of heights and your job was to hang these two posters? Could look like a concentration problem. So I want to point out that every time a parent brings in their kid and tells you that they have ADHD and can't concentrate, you need to think wider than ADHD. Make sense? Okay. All right, I hate these slides, what to look for, because you could put up here pizza. Maybe pizza will make you look like you have anxiety disorder. But I want you to think wide. Avoidance certainly could be symptoms of anxiety. Excessive need for reassurance, sure it could be. Poor concentration or poor performance, certainly could be. Outbursts, be amazed at how often anxious kids have outbursts. Particularly if they're so anxious that they don't verbalize, they're much more likely to verbalize with their aggressive behavior. Okay, I told you I'd put up a slide of the official disorders. This is the only slide that's going to list off all the anxiety disorders that are in both the DSM-4 and the DSM-5. All right, now you may not be all that familiar with the DSM-5 if you're where I think you are in your education. You probably got educated with the DSM-4. Okay, be aware that all of these were basically in one chapter in the DSM-4. In the DSM-5, they turned these two down here, OCD and PTSD, into their own chapters and put some kind of other things underneath of it. So let's pick one. PTSD now has reactive attachment disorder under it, and they've sort of renamed it. Disinhibited social engagement, very interesting. PTSD, acute stress disorder, and other adjustment disorders. So they've sort of scrambled things around, but they have not created any or done away with any anxiety disorders. They're just trying to kind of move the nomenclature around. Okay, so not a huge difference from the DSM-4 to the DSM-5. By the way, there is no child chapter in the DSM-5. It's been completely changed. It's now the neurodevelopmental chapter. That's where tics, Tourette's, ADHD, all of those show up there. Okay, really, we'll be fine. Go home, give it a try. Wash the lights with the lights, the darks with the darks. Separation anxiety disorder. In your packet, you have criteria that I'm going to skip. Okay, I'm moving over to approach. So now I'm going to talk about how to approach a kid or an adolescent that's got an anxiety disorder. You could start with number one, what are practice parameters. Okay, the American Academy of Child and Adolescent Psychiatry, and I've got the site, has practice parameters. Okay, in 2007, they lumped them all together. 2010, they separated out PTSD. 2012, OCD. If you just read the anxiety disorders in 2007, you'll be able to treat them all. Okay? However, Tennessee has done one, best practice guideline on how to treat ADHD, how to treat anxiety, depression, even bipolar disorder. It's short. It's like 5 pages. Really pretty nice handout. Or you could be very familiar with evidence-based research. Or you could do like you were taught in your residency. You had a favorite attending, and they loved Zoloft. And they put all their anxious patients on Zoloft. All right, I can't tell you how many primary care physicians, pediatricians, practice that way. They do what they were basically taught in residency. So I would recommend number one, but if you're not going to do number one, then do number two. If you're not going to do number two, then do number three. There is I'm from East Tennessee, so I can get away with worstus. What's the worstest way to treat anxiety disorders? Don't treat them at all. Okay? Please don't do that. You understand that you all should treat more anxiety disorders and ADHD than a child psychiatrist. I should just get the weird, funky, strange cases. Okay, I stole these from the 2007 practice parameters. And I just want you to be aware kind of overall how you approach it. First of all, you're supposed to screen everybody. I've always thought those kind of recommendations are just ridiculous. Okay? Does your kid think of all the things you're actually supposed to screen for. It's endless, right? Everybody gets up here, tells you they're supposed to screen for what they're discussing. Right? Does it not happen? So what do you really do? You ask a couple of open questions. How's your kid doing in school? How's your kid doing as far as behavior at home? Do you have any major mood issues with your kid? Boy, you think about all the stuff you've just fished for. Now, questions are probably the least important part. What's maybe the most important part of routinely screening? How about observation? What do anxious kids look like in your office? More importantly, what do anxious parents look like in your office? Or their frequency in your office? So you want to put all this stuff together when you're doing your routine screening. Okay? Number two is tough if you're not a psychiatrist. Formal evaluation, really that's just you doing a good job asking lots of questions if anything blips up. Do I expect you to use a UCLA PTSD trauma inventory? Not at all. That's something I would use. Okay, but there are some official evaluation forms out there. You would think wide, that's what multimodal means. Then depending on the severity, you would decide how wide to use. I want therapy, I want a case manager, I want meds, blah, 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 blah. The recommendation number 7 is important. If you're going to use a med, all the parameters out there recommend using a serotonin medication if you're going to use a med. I do not want you to walk away today and think you use meds in all anxiety disorders. I'm going to help you figure that part out. Let's move on. Okay, we're going to talk about differential diagnosis. If I had 12 cups of coffee today and then took Xanax before I showed up, what do you think? Make sense? So you want to think of what else could cause anxiety symptoms, and this is the one I wanted to concentrate with you. So if somebody's got hypoglycemia, boy, they certainly can. Ever seen somebody have hypoglycemia? Boy, do they look anxious. Okay, in 24 years, I've seen one person with pheochromocytoma. They actually didn't look very anxious at all. Okay, isn't that the one we all get tested on over and over and over and over? Cardiac arrhythmias, I've seen hyperthyroidism. Seizure disorders, I've seen some people who truly had seizure disorders, especially like preictal kind of stuff, before it actually happens. Okay, PANDA's very, very complicated. If we have time, we'll go there. I'm going to slide past all of this. Okay, back to treatment. So, I'm going to divide treatment into non-medical and medical. Be aware that CBT, even though it's the buzzword, that there's lots of good evidence for other stuff. Family therapy can be wonderful treatment for anxiety disorders. Okay, the old Freudian psychodynamic stuff, good evidence-based treatment. So somehow we've come to learn that CBT is the only thing to do, but there are some other things to do, but I'm going to concentrate on CBT And obviously, we're going to talk about medical. Okay, CBT, cognitive behavioral therapy. It's in anxiety disorders, it's mostly based in exposure. Let me think of a good story. Last week, I saw a kid who's seeing one of my best therapists. And this kid is young. He's like 7, and he has basically OCD. He can't touch doorknobs because of bugs, germs. He's heard about these germs. He's not old enough to really understand what a germ is, but he's heard about them. And so he uses tissue. He'll pull out his shirt and use the shirt on doorknobs. At school, he's made fun of for doing that. Okay? Can only use his pencil. Can't borrow a pencil because of germs. And so this is causing dysfunction in his life. Okay? All right, this therapist, who is one of my best therapists, has him cutting out pictures of bugs, like parameciae and germs and stuff like that. We've all seen them blown up, and they color them. So in their therapy, they're getting paid to color. Okay, then what do? They cut it out, and the first week they took 2 of them home, and this poor kid had to put them up in his room. Okay, and guess where they ended up? One was kind of behind the mirror, so you could only see it when you walked to the side. He didn't want to see the bug all the time. And the other was under the bed. Makes perfect sense. He got to put it anywhere he wanted in the room. And it was symbolic. It was representative of what he's scared of. Next week, what did they do? They colored 5. He had to put them in his room. Next week, more and more. Eventually, they actually had to make some photocopies. Imagine what this kid now has 8 weeks into therapy. How many bugs are in his room? They're everywhere, even on the ceiling. What have we done? We've exposed him to germs. Guess what he can touch now? Handles. Okay, so he came to see me for a psych eval because it took 2 months to get in and see me. Did I medicate him? Not at all. Whereas maybe if I'd seen him at the beginning, I might have medicated him, which I'm glad I didn't. So here's a classic example of CBT. They did some cognitive stuff, but frankly, a 7-year-old, them abstracting, that's not going to happen much. Okay, maybe a little bit of relaxation stuff. You can talk to a 7-year-old and maybe do some basic relaxation. Okay, I put some quotes in there if you want to know, or some references. If you want to know more about CBT, there's some great references, classic references. Okay, this is one of the really important ones because, frankly, pediatricians make my life a whole lot worse when it comes to this issue. And so I'm going to get on my hobby horse for just a second. Okay, so anxiety disorders impact school, whether you've got a phobia, a social anxiety, separation anxiety. If you've got OCD, it certainly can impact school. Will we all not agree? Okay, well, frankly, you have more interaction with those systems than even I do. And so helping them work through school systems is really, really important. So here are some helpful suggestions. At the very end, I've even got an article for you to go to. Okay, about school refusal. Check-ins are important. So having a spot that they can feel comfortable, usually that's a school nurse. Nowadays, most of our areas have a school counselor. But sort of, if they have trouble getting to school, kind of a place that kind of gets things started. Okay, one of the best ones is dad dropping off and not mom. I can't tell you how often we treat school refusal with dad taking them to school. Okay, allowing extra time between classes. Okay. Sometimes we allow kids to arrive late at school depending on what's happening. If it's more of a parent issue, a lot of parents just don't get their anxious kids to school because the parent's just as anxious. We often won't give in on that one. So you want to think through that. Okay? Probably the most important one is developing a safe place at school. In other words, what's more important, attending school or academics? People struggle with this. Actually, attending school is more important. Why? It's where I learned how to get along with geeks, goths, rednecks, jerks, preps, druggies, mean teachers, jerk teachers, nice teachers. Think about all the stuff you learn at school. Now, do I think academics are not important? No, I think they're really important. But if you don't attend school, very tough to get educated. And so to some degree, I'm going to put academics on the back burner and develop a safe place at school where they'll go. That's often where? Library, often school nurse, counselor. I have one autistic kid who's very anxious who likes the police room. You know what that is? It's the principal's office. If he gets really nervous and overwhelmed at school, he's headed to the police room, which is the principal's office, and he would prefer to sit there, the most protected place in the school. And that's his escape valve. A pediatrician, a good pediatrician in town developed that, not me. Okay, and that kid is being educated well because we've got this escape plan. Okay, why did I put down there don't use homebound? Because it makes you look wonderful. It solves the problem, always solves the problem. Is the kid anxious at home? No. Do the parents have to get up and get him to school? No. What kind of grades do you make in homebound? Straight A's. I've never met a kid that didn't make straight A's in homebound. Seriously. No kid has ever failed homebound, ever. Okay, but what happens? Their anxiety gets worse over time. I think I've got time for a war story, and it's literally a war story. I was in the military, so I want to tell you how they handled shell shock in World War I versus World War II, and this is all true. In World War I, if you were in Europe and you got shell shock, and hopefully you know what that is, you became overwhelmed with war. Okay? They sent you back to the local hospital. So if you were in France, you went to the France hospital. And as soon as they could, they got you back on a transport to a hospital in America. This is World War I. Okay, and you went into their psych ward or however they treated it back then. What happened to about 90% of those shell shock guys? Remained functional? Marriages? Hold a job? Not at all. Over 90% became dysfunctional adults. Okay, so the military researched it for years. World War II, what did they do? Soldier gets overwhelmed. He goes to his battalion aid station, which is one terrain feature away. So if the war is down in the valley, you go up and over the hills on the other side. What can you hear the entire time you're at the battalion aid station? Killing, bombs, shooting. At the battalion aid station, what do you get? What I call 3 hots in a cot. If they can't sleep, they're given something to sleep, a chance to get away, but the whole time, what can they hear? What's scaring them to death? Okay? Then what happens after 24 hours and some good sleep? They go right back to what was overwhelming. Okay? Now, assuming they lived, and not all of them did live, what happened to them when they came back to America? Completely functional. Held jobs, got married, and to some degree they could even brag about. It was so overwhelming, but I faced my fear. I went back and, I don't know, manly or something like that. Okay? And so that principle is really important. So you tell me, homebound, World War I or World War II? Yeah. And so, sure, there's times to use it, particularly for medical issues and all that, but be very, very careful. I've signed for 2 and 24 years. Okay, and they were both very short term. Okay? Remember, I see kids at the point where they feel like they need it 6 months later, 2 years later. I see people 20 years later after they did homebound for 6 years, and they're dysfunctional. Okay, so please don't do this, or if you do, get the help of somebody who's used to treating this. Okay, in the end, you're here because you want to know how to treat. So let's get back into that. So when do you use a medication? In the end, it comes down to severity and the D word. What is the D word? Dysfunction. So how functional are they versus dysfunction? Okay, so this is when you choose a med, and this is going to help me. So dysfunction is one word, but here's a little bit more that's going to help me decide when to medicate and when not to medicate. The younger they are, less likely I'm going to medicate. The older they are, more likely I will. Less severe impaired, obvious. CBT, if there's no CBT, I almost refuse. In fact, I do refuse. I will not medicate a kid unless there's another form of therapy on board. Okay, and I would generally recommend the same for you. Okay, and you have a lot of power there. I'm sorry, I won't refill your Celexa, your Zoloft, unless you're going to the therapist like you told me you were going to do, because that's so much safer than anything I prescribe. And do you want Susie or Johnny to be on these meds forever? There's so many different ways to verbalize that. And so you do have a bit of a bully stick. Okay? If there's no family history, I'm much less likely to medicate. If there's a terrible family history of everybody having anxiety, I'm much more likely to medicate. Okay, so those are some things that are going to help you kind of figure this out. Okay, and all the parameters, they all come down to this. I find this almost worthless, but you have to present it because of this thing at the bottom. So CBT only when it's mild anxiety, very little dysfunction. CBT, cognitive behavioral plus medicine, when it's kind of in the middle. And if it's severe, always use a combination of the two. And I'm going to give you some research to support that. But I'm going to tell you a story. True story. I have worked for Frontier since '97, except for a huge mistake in my life. My parents, when I grew up in Cokeville, when I graduated, they went to Fort Lauderdale. I married my wife from Fort Lauderdale. She has family in Fort Lauderdale. So I made the mistake of my life by what? Moving by family. All right? So I moved in and had a private practice in the richest part of Fort Lauderdale. So my kids went to the rich Christian school, the rich Jewish school, the rich Muslim school, the rich school, the rich Catholic school. Didn't take any insurance, everybody just paid me cash. That's the kind of practice I had for 5 years. Hated it. Made a ton of money, hated it. Okay? I want to tell you about my first year there in the rich, I can't remember which rich school it was. The second grade teacher was an old battle axe. She was 500 years old. Okay? She referred 7 boys from her class. Guess how many kids she had in her class? 14. This is not a joke. She literally sent me. I was the new child psychiatrist in town. Right? Triple boarded, blah, 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 blah. Okay? Sends me Vanderbilts and Connors, all 3s, if you're familiar with them. These kids are hellions, the spawn of the devil. Okay? So I'm looking at the information. I got the teacher information. I've not met the parents yet. Kid comes in. Now let me tell you about Johnny, 2nd grade. In kindergarten, what did he make as far as grades? They actually gave this kid grades in preschool. Right? You do that if you're paying $5,000 a month. You're going to get grades, believe me. He made straight A's in preschool. Kindergarten, what did he make? Straight A's. 1st grade, what did he make? Straight A's. What did this bold battle axe do? She gave this kid his first B. How dare her? Filled out a Vanderbilt or Connors, all 3s, sends them to the new child psychiatrist. Okay, now what am I already thinking? Come on. This is a joke. This kid made a B in this school. He's completely functional. Here's the problem. Who walked in with the kid? Dad and Mom. Let me tell you about Dad. Dad is Dr. So-and-so. He went to Harvard. He's done the best residency. He's the best known cancer doc in Fort Lauderdale. Let me tell you about Mom. She's Judge so-and-so. She went to Yale. Best law school ever. She's well known. Is the kid dysfunctional? I heard somebody murmur no. Is the kid dysfunctional? Is the kid dysfunctional? If he's going to Harvard, is he dysfunctional? I know how I feel about it. Of course, kid's completely functional. He's making B's in a hard school. I mean, he's made A's all the way through, as normal as could be. But if you're the parent, do you go to Harvard and Yale if you're making B's? So their definition of dysfunction was completely different than mine. And basically, I upset all those parents. I refused to medicate them. I'm aware of 3 that went to their pediatrician and got ADHD drugs. And what happened to the kid? Did his heart stop and did he die? No. What happened to the kid? He made A's. Why did the kid make A's when he did not have ADHD? Really important principle with ADHD. What's the most abused prescribed drug on college campuses? Adderall. All those kids have ADHD? No, because Adderall or stimulants help everyone's concentration. Does that make sense? Well, how far am I into this? Well, I gotta hurry. Okay, let's keep going. Let's tell another war story. Okay, jump into the meds, SSRIs. They are first line. I'm going to take this pie of SSRIs and divide it many different ways with the next 3 slides. Okay, these are the most often used meds for anxiety disorders. One of them is not even an SSRI, anafranil, clopidogrel. But frankly, historically, it's been used by more than anything else for treating anxiety in kids. Why? Because we've been treating it for hundreds of years. Well, not that it's been around that long. Okay, Prozac came out my 2nd year in residency. Wasn't around when I was in medical school. So what did we use? We used anafranil back then. Okay? Most used. This is FDA approved. Slide looks a whole lot different. All right? And does anybody see social anxiety disorder up there? Anybody see generalized anxiety disorder? Anybody see separation? No. So these drugs are only approved for OCD. Okay? Now let's monkey it up a little bit more. Now I added other mood disorders besides bipolar. So now I've added major depression. Okay, the list gets a little bit longer. I think that's it. This is from the Tennessee Best Practice Guideline. Look what they did. They included Luvox, Paxil, Paxil CR, Celexa. These drugs are not FDA approved at all, but they are evidence-based. They can quote literature that supports their use in kids. So, do I care if it's FDA approved? I don't. You might want to. There's reasons why you might not want to. It has a lot to do with lawyers. Okay? Follow the practice parameters. I'm going to give you some specifics in just a minute. Wellbutrin is not an SSRI. If you want to make somebody worse who's anxious, give them Wellbutrin. It's a norepi drug. They will come back and cuss you out. I've been cussed out many times doing that very thing. It's a great antidepressant. It's a miserable serotonin drug. Or excuse me, miserable anxiety drug. Okay, probably the reason you showed up today is this slide right here. You want to know, when do I use Prozac? When do I use Zoloft? When do I use Celexa? When do I use Paxil? So I'm going to give you my Musil approach. Okay? And I teach psychiatric residents and blah, blah, blah. So my answer is you pick the SSRI by the side effect that you want. Because all effective drugs have effective side effects. Really important principle in medicine. Effective drugs have effective side effects. Penicillin, does it have side effects? Tons. It's an effective drug. Whereas Buspar, no side effects, because it barely works. Okay, so learn the side effects of the serotonin drugs. You don't know which one to use. So this is how I teach it. I teach it by activating to sedating. So my two activating are Prozac and Zoloft. My two middle of the line, and they don't generally cause weight gain. My two L's, Luvox and Lexapro, are middle of the line. They don't activate, they don't sedate. My two calming, Celexa and Paxil. That's all you really have to remember if we're talking SSRIs. Now I've ignored Effexor, Cymbalta, Prestige because they're not SSRIs, they're SNRIs, which I would not generally use in kids. Okay, or let me use them. Okay, so I'll give you a case. 10-year-old girl, she's overweight, she sleeps all day long because of her anxiety. When she gets home from school, she sleeps because she doesn't want to interact with anything. Whenever she's nervous, she eats. She's a slug. What are you going to give her? You're going to give her Celexa and Paxil, make her more tired and eat more? Not at all. And I can tell you the opposite kid. The other kid can't sleep because he's nervous, always moving, fidgeting, right? Can't eat. Well, you're going to give them Paxil and Celexa. That make sense? So learn them by the side effects. Black box warning, I'm going to fly through this because I was going to spend more time, but I've been talking too much. Just be aware that, I do want you to see this. Be aware that there is a chance that you can make someone worse with any mood medicine. Okay? And if you make their mood worse, you could create or feed thoughts of suicide. If I have time, I'll come back and tell you more war stories on that. What I really want you to see is parentsmedguide.org, O-R-G. If you put in comma, you can get there. This is a screenshot of that. The FDA, DEA required all drug companies that make meds that are used in kids to come up with this site. And so you can print off the PDF for ADHD, for bipolar, and for depression. All the anxiety drugs are in depression. And so I don't prescribe one of these drugs without printing one of these off. Okay, and I hand it to them. And it has all the information you ever want to know about using a serotonin drug in any age kid. Great site. Strongly recommend it. Okay, by the way, since they came out with a black box warning, suicide rates in kids, teenagers, were coming down, coming down, coming down, coming down over the years until the black box warning. What happened to the suicide rates? Started going up, and they're still going up. Why? How come? Prescribing fewer, but more importantly, delay in treatment. Up until that time, pediatricians, family practice docs were very comfortable giving serotonin drugs. Since then, they're very uncomfortable giving serotonin drugs. And so it's delayed treatment. All right? Now, am I saying that there's no risk of suicide with serotonin? Not at all. Okay? All right, let's keep moving. So I picked these 3 serotonin drugs because these are the ones that I like the best. If you told me that Paxil's better than Celexa, I would agree with you. If you told me that this drug, I don't care which 3 you pick. I just care that you have one from activating, one in the middle, and one from sedating. Everybody okay with that? So I'm going to tell you the three I use, and if you tell me you like one another or your attending's teaching you another, great. I think that's awesome. Just know where it is in the spectrum. Okay, I just wanted to point out citalopram and Celexa and Lexapro are isomers. Only difference is the ES, right-handed versus left-handed. Chemistry, everybody okay with that? Chemically, exactly alike, but in reality, they're what? Mirror images. So if we shake hands with me? Right-handed. If I stick my left hand out to his right hand, does it fit well? Okay, that's an isomer. This is a much better fit. That's all that means. Okay? The chemical for lemon and grapefruit, just isomer. Exact same chemical compound, but put together different. One smells like grapefruit, the other smells like lemon. Anyway, okay. So let's talk one of these. Celexa Citalopram. It's Europe's Prozac. They make fun of Celexa in Europe like we make fun of Prozac in America. Dosage range is 10 to 40. I wouldn't recommend using more than 40 unless I do it because of risk to QTC. It comes in 10, 20, 40, and it does come in a liquid. The liquid tastes like diesel fuel. This principle is important. I'm going to have each slide is going to say this. When you start a serotonin drug, always start a ridiculous subtherapeutic dose. Subtherapeutic dose, a water dose. Why? Who's anxious? Who has somatic symptoms, belly aches, diarrhea? They do. They're anxious. Right? And you're about to put something in them? And so start something that can't have a side effect. Okay, now I don't take that approach with depression, but with anxiety, boy, I'm willing to waste 2 weeks to win their trust before the drug becomes effective. So use tiny, tiny, tiny doses until you've earned their trust and they don't think their head's going to fall off. Okay? So I generally write my script, half a tablet for a week, and then I tell the parents, by the way, if you're still experiencing anything weird, just keep giving the half. And if you need to break into a fourth, that's fine. Work your way up to a whole tablet. Okay? And again, with anxiety, start low doses. Okay, Lexapro, same basic plan. Dosing's a little bit different. Okay, it's a little bit more potent because it doesn't have the sludge of citalopram in it. It's the cleaned up form. It does have FDA approval down to age 12 for major depression. Okay, Zoloft is kind of the classic drug. It is FDA approved down to age 6 for OCD. We use it for a little bit for everything. It's the drug, SSRI, most likely to give stomach aches and diarrhea. I use a ton of it, but watch out for stomach aches and diarrhea. If you have a kid that's anxious with that, this might be my last choice. Okay? All right, if you go over 100 milligrams, you now have an ADHD drug. It has dopamine effect. That's how stimulants work. So if you can get to 100 milligrams, you can also improve concentration. It's the only SSRI that fits into that category. It comes in 25, 50, 100, and there is a liquid, but it's hard to remember. It's 20 per 1. In other words, 100 milligrams per teaspoon. It's hard to remember that. At least I have a hard time remembering that. Okay, by the way, you dose Celexa at night because it's calming. Lexapro, I don't care when. Zoloft because it's activating. You want to give it at night? Oh, give it in the morning. The exception is sometimes I want to send kids to school sedated and tired. Why would I do that? They're anxious. If they sleep at school, I've still accomplished getting them on the school grounds. Okay? All right, side effects. I think you know these. I'm not going to spend much time with these. I want to get on with this other stuff. More side effects. This is an adult study. Okay, outcomes. This is a really nice study. We refer to it as the CAMS, the Child Adolescent Anxiety Multimodal Study. This was done in the final 3-year outcomes was completed in March 2014. An enormous study, 488. What they did is a computer randomized. Some kids got combo, got CBT, and all these kids were on Zoloft. Some just got CBT counseling only, no medicine. And who picked this? The computer did. So the computer didn't care if you had mild anxiety symptoms or severe. The computer just randomly did this. Okay? The computer didn't care if you had stomach aches or not. It just randomly decided who got Zoloft and who didn't. Okay? Some just got Zoloft and the rest got placebo. And placebo works how often? At least 20%. And often more than that. Okay? So if you stand and wiggle and jump up and down, 20% of the time your patients will get better. For real. Okay. So here's the outcomes. 80% better, combination at 12 weeks, 3 months, down. How about 36 weeks into it? Look at the results. Okay, again, the computer decided this. I hope I'm better than a computer. Computer randomized. Better than a flip of a coin, I hope. Okay, what happens over time? 12 weeks, 24 weeks, 36 weeks. I'm going to have to speed up. Okay, they're anti-anxiety pills, but I'm afraid to take them. I don't have a case where I'm treating anxiety where this isn't a major issue. So you really want to dive into this early, and I kind of use humor to deal with it. Okay? And by the time they get to me, you've already put them on 3, and they've all had stomach aches to them. So what am I really dealing with? I'm dealing with anxiousness to meds. Okay? All right. Think. Pregnancy, somebody's reproductive age, you need to do some protection. Okay? I don't prescribe SSRIs to teenage girls unless I've at least recommended, and if they're impulsive, I require. Okay? That's me. I'm not telling you you have to practice that way. That's where I am with it. Okay? But I also treat a population that's very impulsive. Suicide, I've already talked about the suicide risk. I really want to get to these issues. Could we up the dosage? I still have feelings. I really can't tell you how many people come to me for that very issue, particularly adults. Opiates, huge problem in our area. Why? Who wants to have feelings? Question. This is for the attendant. The residents can participate. If you're overwhelmed more than 3 times a week, raise your hand. Come on. Yeah. I view being overwhelmed completely normal. That's my view of it. Okay, now, when I'm overwhelmed, I don't have an affair, go to the beach, spend all my money. I mean, the list is endless. Shoot up, take Xanax. I tolerate my feelings. Some people just want you to medicate normalcy, normal feelings of life. And you really have to figure that out early. Otherwise, you'll be a miserable failure. Compliance is the biggest reason these don't work. Serotonin drugs should work 70% of the time. 30% they'll come back and tell you you're worthless. 70% of the time they'll work. However, how much do they work? By the way, it's the same answer for ADHD drugs. The answer is right there. How much do they help? 50%. If you're a parent of an anxious kid, how much help do you want? 100%. I'll just take 50% help, please. No, you want 100% help in the kids I treat. The parents want the medicine to wash them, bathe them, teach them, educate them, discipline them, and parent them. Okay. So, figure out early and document your target symptoms. Okay? Antidepressants is the greatest example. I'm going to medicate you until you're happy. Think about that comment. Okay, now, if I play the lottery today and I win $1 million, how do I feel? Pretty freaking happy. Okay? If my wife calls me and one of my 3 kids has leukemia today, how do I feel? Zoloft is going to stop that? Think about your target symptom. So, what are serotonin drugs supposed to do? Sleep, appetite, vegetative symptoms of anxiety, vegetative symptoms of depression. They do not create happiness. They don't stop anxiety. Some anxiety is wonderful. And so I spend a lot of time negotiating, wrestling with people on what's an appropriate target and outcome for these meds. Okay, enough preaching. How long do you medicate? If they're depressed, 6 to 9 months. If they have an anxiety disorder, up to a year, because it takes longer for the improvement to stick around. Pick when you want to come off the meds when you're ready for the symptoms to come back. When is that usually? Near the end of the school year. That's when I most often do it. Sometimes I'll do it before Christmas. That time. Okay, what is the only cure for anxiety? Don't yell out of medicine. I told you a minute ago, 50% improvement with meds. 50% improvement with CBT. What's the only cure? 100% cure. It's an important concept. Right? Death? I've got a better answer, I think. I agree, but what does that involve? I'm sorry? Facing it, does it make the anxiety go away? I think facing it's really important, but it doesn't necessarily make it go away. It might shrink it. What's the cure for anxiety? Trust. if ever you can slip that in, what do you trust? Really important concept. Okay? All right, I'll leave it there. SSRIs are not the most used meds for anxiety disorders. Not at all. Most used meds for anxiety disorders in children, I don't want to talk about Xanax and Valium and all that, is Benadryl and clonidine. Isn't that what you use for sleep when you're prescribing in the clinic? No FDA-approved drug for children in sleep. So what do we all use? An alpha-2. Used all the time. So the truth is, we use Benadryl all the time for anxiety. Okay? By the way, it's the drug most likely to cause akathisia. What's akathisia? Movements. Can't stomach. If I take 75 milligrams of Benadryl, which is 2 Advil PMs, I don't stop moving. I look like I'm jonesing. I just can't stop moving. Legs move into bed and all that kind of stuff. But 50, yeah, I sleep great. All right. Buspar, worthless. Benzos, please don't use them in kids. Please don't. And if you do, make an agreement that you'll only use them for 2 or 3 weeks, maybe a month. Don't ever tell somebody under the age of 18 that you're willing to prescribe benzos long term. If you do, please send them to me and get me involved in that. Okay, summary. Consider medicating childhood anxiety disorders depending on the severity and the D word, dysfunction. Know at least 3 SSRIs. Please don't know 1. SSRIs do not treat a diagnosis. Zoloft is not approved only for social anxiety disorder. They treat symptoms and clarify the target symptoms. School interventions, please, that's really, really important. Have a referral base. And I told you I'd end with this. You really need to know all about school refusal. And here's a great reference for it. Okay, I think I went longer than I expected. How are we doing on time? How much? I'd like to try and answer any questions I can. If you need to go, but I'll stick around. Yes, real loud so everybody can hear it.
So what would be the best way to get a kid back into school that has already been told not to go to school by another?
Boy, the best way that I've found is make them hate me. Honestly, I try and make them like you, and make them hate me, and they'll love their therapist. They can sit in therapy and talk about what an a-hole Dr. Musil is. So you need somebody who's willing to be mean enough and have big enough shoulders to get them back in. The way I do that is I negotiate 1 hour. I need you on the school grounds for 1 hour, and if that needs to be after school, I'm willing to do that for a month. And so I'll come up with somebody who's willing to sit with them from 3 to 4 o'clock. And then after a month of doing that, then it's from 8 to 9 in the morning in their favorite place. Not in the classroom, because that's too fearful. Okay? And I add time. Schools don't want to do that. That requires a lot of staff, and so it requires a lot of interaction, a lot of calls back and forth. That's how I accomplish that. The whole time telling them, I'm going to treat your anxiety, I'm going to decrease it by 50%. I can't take it completely away. Who's rough enough and tough enough in your house to walk that kid into school? Okay? I used to tell parents, don't answer their cell phones. I got in huge trouble for that. Right? They call it 11:30, Mommy, come get me. You can't tell them that anymore. Okay? That's the basics. But generally, you've got to have somebody that's bad enough, mean enough to make it happen. Okay? And so many primary care docs don't want to be that person. And I can understand why. Other questions or comments? Okay, you have one other handout. It's a review of SSRIs in treating anxiety disorder, and it's all the hard data. Percentages, what's FDA approved, a little bit about CBT. It's 3, maybe 4 pages. If you were going to read one article about using medicines for anxiety, it's that article. Okay? Because I know you don't have a whole lot of time. Okay, well, thank you very much. I appreciate it. And please treat some anxiety disorders. You treat more than I do. Thank you.